Good evening, everyone. It gives me great pleasure to welcome you all to tonight's topic. The NIP is streamlined for pneumococcal vaccination in children, but challenges still lay ahead for adults and individuals with medical conditions. My name is Professor Peter Richmond. I'm a paediatric immunologist and paediatrician at Perth Children's Hospital, and I'm also an immunisation researcher at the Kids Research Institute of Australia and the University of Western Australia. I'm really delighted tonight to be chairing tonight's meeting on the important topic of pneumococcal disease and vaccination for the protection of children and adults. But before we start, I would like to provide an acknowledgement of country. In the spirit of reconciliation, the Immunisation Coalition and myself acknowledges the traditional custodians on the lands on which we all work, which for me is the Whadjuk people of the Noongar Nation from the Perth region, and pay my respects to their elders, past, present, future, and any Aboriginal people joining the webinar tonight. I would also like to celebrate the diversity of Aboriginal and Torres Strait Islander peoples and their ongoing cultures and various connections to the lands and waters of Australia and the wisdom and the knowledge that they provide us. I would also like to remind us that of the burden of pneumococcal disease that First Nations communities around the world suffer and the importance of reducing this through improved immunisation and treatment. We are here tonight to honour the memory of the late Professor Allan Cripps, who contributed significantly to the prevention of pneumococcal disease through research, mentoring and advocacy on a national and global level. And we will be providing an update on prevention, particularly around the recent National Immunisation Program listing of Prevnar 20, but also the challenges ahead for vaccinating older adults according to recommendations. So tonight we'll be covering the following areas: reviewing the epidemiology of pneumococcal diseases across the age groups, reviewing the childhood immunisation program, including the addition of Prevnar 20 onto the NIP for children under 5 and for individuals under 17 years of age with risk factors. And finally, to review the control strategies for pneumococcal disease in older adults and those living with comorbid conditions that places them at increased risk. As a reminder, tonight's webinar is an RACGP accredited activity, is being recorded and will be sent to you via email in approximately 1 week, so you can look at it again. Tonight, joining me are two well-known, very experienced and respected immunisation and infectious diseases experts. In order of presentation, I would firstly like to welcome Angela Newbound. Angela is an immunisation education consultant based in South Australia and is a member of the Immunisation Coalition. She has been involved in the immunisation program delivery in South Australia for over 24 years, originally as an immunisation provider and then in various program coordinators within the divisions of general practice, South Australian Health Immunisation Section, Medicare Local Network and Primary Health Network. Angela has and continues to provide clinical advice, support and education to a wide range of immunisation providers. Welcome, Angela. And secondly, Professor Paul Van Binder. Paul is a public health physician and past chairman of the Immunisation Coalition. He's a professor in the School of Medicine at Griffith University in Queensland and has held senior public health positions in a number of Australian states and in 2 Canadian jurisdictions at the Centre for Infections in the United Kingdom. He's also held personally appointments on the National Immunisation Technical Advisory Committee across 3 continents, is a reviewer of over 10 journals and has over 80 refereed book chapters and articles to his name. Welcome, Paul. In the interest of time, we will be answering the questions at the end, but we would encourage you to submit your questions at any time using the Q&A function at the bottom of your screen. And finally, we would like to acknowledge MSD and Pfizer for supporting this educational activity. Now let's get started. I would like to hand you over to Angela for her to present on new NIP listing of Prevnar 20. What does this mean for children and individuals under 18 years of age with risk factors? Thank you, Angela. Just a reminder, we will take questions at the end.
Thank you very much, Peter. What a kind introduction and what a privilege it is to presenting this particular presentation tonight on such an important webinar. These are just my declarations, but in the essence of time, let's get right into it. Well, of course, this is the big announcement, isn't it? This is it's absolutely great news, and the Department of Health, Disability and Ageing has announced those changes to the National Immunisation Program Childhood Pneumococcal Schedule, following advice from the Australian Technical Advisory Group on Immunisation, or ATAGI. So, as you know, from the 1st of September 2025, Prevnar 20 will replace Prevnar 13 and also Pneumovax 23 for children. And all First Nations children will now receive the 4 doses, ensuring that there's national consistency. So what does this, really look like? This is going to be a real whirlwind overview of these new pneumococcal vaccine recommendations for children. And yes, they're trying to simplify the program, but it still means that we have very busy slides to share, unfortunately. So look, going through the list very quickly, non-First Nations infants commencing their program now are just going to be receiving Prevnar 20 at 2, 4 and 12 months. So it's just a straight swap over from the 13 valent. Like I said, now all First Nations children are recommended to receive Prevnar 20 at a 4-dose schedule at 2, 4, 6 and 12 months of age. Previously, though, you would be aware that only First Nations children living in Northern Territory, Queensland, Western Australia and South Australia received those 4 doses of Prevnar 13. And this change really is based on those higher rates of disease in some First Nations communities, especially near state borders where different vaccine schedules were being used. Obviously, in previous schedules, all infants with medical at-risk conditions listed in the handbook received 4 doses of Prevnar 13, and these infants now will receive those 4 doses of Prevnar 20. Obviously, for those children that have already commenced their pneumococcal vaccination course with Prevnar 13, they will now just complete their course with Prevnar 20. There's a few little points that you need to be aware of. First Nations children in Northern Territory, Queensland, Western Australia and South Australia that have completed their pneumococcal conjugate vaccine doses with your 13 valent are recommended to receive a single dose of the 20 valent at 4 years of age or 12 months after their last dose of conjugate vaccine, whichever is later. If these children have already received that first dose of their Pneumovax 23 following their 13 valent course, they are recommended to receive a single dose of 20 valent at least 5 years after that dose of the Pneumovax 23. First Nations children in Northern Territory, Queensland, Western Australia and South Australia that have completed their conjugate vaccine schedule with 13 valent and they have received both of their doses of Pneumovax 23, they do not require any supplementary doses of Prevnar 20. For those First Nations children living in all the other states and territories, so ACT, New South Wales, Victoria and Tasmania, without any risk conditions at all, and they would have previously received a 3-dose schedule. And if they have not yet completed their conjugate vaccine schedule, then they would, and who have completed, they don't require any supplementary doses of 20 valent either. Children with risk conditions, obviously previously recommended also to receive Pneumovax 23 at 4 years and a second dose later. But if these children have not received their first dose of 23 valent, they're recommended to receive a dose of 20 valent. And they should receive that dose at 4 years of age or 12 months after their last dose of pneumococcal conjugate vaccine, whichever's later. If they have already received that first dose of Pneumovax 23, then they should just go ahead and receive a single dose of Prevnar 20 at least 5 years after that first dose of Pneumovax 23. Children that are 12 months of age and older, but under 18 years of age, so they have not yet had their 18th birthday, with a newly diagnosed risk condition, they are recommended to receive a single dose of Prevnar 20. Depending on the risk condition, this dose may or may not be funded under the NIP. For example, if it's an 11-year-old newly diagnosed with diabetes, they would not be eligible for funded NIP vaccine, but it would certainly be recommended that they receive the dose. Whereas if you had an 11-year-old having a cochlear implant, then they would be eligible for NIP funded vaccine. Just remember, your hematopoietic stem cell transplant patients are still recommended to receive the 3 doses after transplant, regardless of previous pneumococcal vaccine history. So this is the new schedule for the childhood schedule. So please ensure that you take the old versions down off your wall and replace them with the new version. And of course, and then you've also got your adolescent vaccine schedule as well. And of course, if they have got medical risk factors that put them at risk of invasive pneumococcal disease. So I suppose, this was the complexity here of the previous schedule. This is what they're really trying to get us to. But this is probably actually where you still are at. They are trying. I think a few people are nodding. It's still easy to be confused though, but over time you'll become familiar with the schedule, and we yet to see what they're going to do with the adult program, but Paul's going to talk to us about adult recommendations shortly. So very quickly, this data just looks at fully vaccinated children, looking in comparison from 2020 to 2024. And we can see we are just sliding backwards with our vaccine uptake, and we really can't afford to be doing this. This is a really serious disease, and we need these children to be fully immunised. And I'd just like to really point out here that in 2024, according to ABS data, there were about 312,500 odd children aged 5 years in Australia, so 5-year-olds. So when we're looking at this data, and we can see, look at the 60-month-olds, for example, there's been that 2% drop in vaccine uptake since 2020. It only is a small percentage, but it really equates to about 6,000 children not being fully up to date with their vaccine program. And I think, we need to really pay attention to these figures. If we're looking at, the annualised percentage by state at 12 months of age, and we're looking at pneumococcal vaccine uptake, we're doing pretty good. We're mostly just shy of that 95% vaccination coverage target set by the government. So well done there for ACT and Northern Territory for reaching that target. If we're going to be looking at the 2-year-olds, we can certainly see, there's some room for improvement. Usually we're about now, the rates pick up a little bit because children that got behind with their baby program, etc. But at the moment, they're just lagging behind a little bit more. Just shy once again of that 95% target, but once again, well done ACT and also Tasmania. So this graph demonstrates the effect that pneumococcal vaccines has had on pneumococcal disease over time. And each time a new extended valency vaccine has been introduced, notifications of invasive pneumococcal disease have reduced, but over time notifications tend to rise again. And this does not at all mean that our vaccines are not working. They've done a fabulous job with the serotypes that they've been designed to protect against. But serotype replacement does occur, and therefore there's always going to be that need for higher valency pneumococcal vaccines that are going to provide that protection against more serotypes. So this is sort of a bit of a table that shows, what is around, etc., what has been around. You can see here the serotypes that Prevnar 20 is going to be able to provide protection against, and obviously better protecting children against pneumococcal disease. So in regards to, the serotypes distribution by vaccine in children less than 5, this is sort of 23-24 data. The decision really to offer Prevnar 20 to children under the National Immunisation Program is really based on this data and what serotypes are causing the most invasive pneumococcal disease in infants and these young children. So Prevnar 20 covers about 63% of invasive pneumococcal disease causing serotypes based on current epidemiology. So that's about 30% more than Prevnar 13 and about 13% more than the PCV, the pneumococcal conjugate vaccine 15. If we were to look at those really young children, so those that are up to 2 years of age, we can see that this is really good data as well, covering PCV covering 30% more IPD than the Prevnar 13 did, and about 16.5% more than what PCV 15 is. So, serotype 3, often referred to as the sugar-coated killer because it is just such a difficult serotype. It still has to be watched very closely. It's got a very, very thick polysaccharide layer around it, so it tends to evade our immune system a bit better, and it just is a bit of a hard nut to crack with the vaccines that we have access to. So just really urging everybody that's a healthcare professional out there to have conversations with patients around the importance of these vaccines and really the seriousness of the disease. Check the AIR, identify your overdue kids, anybody that's missing any vaccine data, you can add that in. But just remember that if you can't find any evidence of a vaccine being given, the handbook will say go ahead and assume that they have not had the vaccine and vaccinate them. We cannot over-vaccinate people. Your patients are looking to you to guide them. So please, the healthcare provider recommendation is just so important. Inform them when the next dose is due, help them make an appointment on their way out the door, let them know what's funded, what's not funded. Use your practice management systems to add in the vaccine recalls. And there's lots of resources for you. The PneumoSmart tool on the Immunisation Coalition website is currently being updated to reflect the changes to the pneumococcal vaccination program for those under 18 years of age, specifically with this update of Prevnar 20. Also, Pfizer has this great wall chart. It's a lovely resource, and that's available to providers as well. If you haven't got a copy of it, perhaps contact your Pfizer representative. So I can't stress enough really to providers to always triple check your vaccines, once at the fridge, once with another healthcare professional, or even with the patient, once, again, just prior to administration. You are now going to have 3 pneumococcal vaccines in your fridge. You've got your 20-valent conjugate for people under 18 years. You've got 13-valent for people over 18 years of age with medical risk conditions, and for your healthy Aboriginal Torres Strait Islander people at 50 and your healthy non-Indigenous people at 70 years of age. Also, you've got your 23-valent vaccine for those people over 18 with medical risk conditions, and for those healthy Aboriginal Torres Strait Islander people at 50 years of age. And so really triple checking will help prevent these vaccine errors, because if you make a mistake, you should really report it to your state health department as a program error and seek advice. And then you've got an uncomfortable conversation to have with your patient. So just making sure that you're really flagging your at-risk patients and age-eligible patients in your practice management system that you're using. Have a little bit of a look. Is it possible for your practice to improve access? Are you using accredited nurse immunisers, vaccinating autonomously in your practice? And that's up to state and territory legislations. Have you got nurses that are working understanding medication orders? Unfortunately, those nurses can't draw a Medicare item payment for vaccinating because at the moment it is GP-led care, and therefore a GP must see the patient to receive any item number funding. Can you do a targeted recall activity using the AIR 10A reports, the due overdue reports? Can you think of a quality improvement activity that you can increase vaccine uptake with? Paul is going to guide us through the medical conditions, I'm sure, that increase the risk of pneumococcal disease, but it is complex. So please, as a provider, download this guide out of the Australian Immunisation Handbook. It'll also tell you what's funded and what's not funded. And remember, this criteria also applies to those under 18 years of age. Their medical condition must be one that is eligible to receive NIP-funded Prevnar 20 pneumococcal vaccine. Otherwise, you would be recommending it if it's not funded for them. So your older patients, and I'm not going to go into this because this is really, you know, Paul will talk about the older patients, but certainly trying to normalise pneumococcal vaccine and adding it into care plans, etc., is really, really important. So just finally, really vaccines are designed and developed to provide protection from disease, but the act of vaccinating is the act that provides the protection. So ask patients every single time you see them, are they Aboriginal and Torres Strait Islander? Because it makes a difference as well. Check the AIR. You know, you can make the difference in vaccine uptake just by your healthcare professional recommendation. Really keep advocating for vaccination with whoever you possibly can to make sure that we've got good equity, we've got good vaccines available. So key take home, no more Pneumovax 23 for children, and the adult vaccination recommendations around pneumococcal vaccines are unchanged at this stage. So that is me done in a whirlwind, Peter. So I'll just stop sharing my screen, and thank you very much.
Thank you so much, Angela. Just a reminder, and thank you for those people who are starting to post questions on the Q&A. We'll be answering those after the next talk. So I would like to now invite Professor Paul van Binder to present on reviewing of the control strategies for pneumococcal disease in older adults and those living with comorbid conditions. Thank you, Paul.
Thanks, Peter. So my talk is going to be a little bit different to what was advertised and what people were saying, in that, as Angela pointed out, there has been no change to the Australian recommendations at this point. We've been waiting on the publication of an adult review of pneumococcal disease for a while, and I expect that a decision will be made to now I'm not sure what's happened here, but anyhow, that a decision will be made to go for a new tender and to introduce a new adult pneumococcal range in the middle of next year. This is a background, and the slide hasn't come up very well. I do want to identify the fact that although this is a truncated only 1 hour session this year compared to past years, I do want to acknowledge the incredible work of Allan Cripps, who was raised on a rural farm and school by correspondence, and then from there became one of the foremost researchers in mucosal immunity, and he was a practical researcher. A lot of what he did led to the development of the vaccine assays to the development of practical solutions to the problems that we were facing at the time. He was an incredible academic. He was made Professor Emeritus at Griffith University. He actually founded the journal Pneumonia because he saw a need for that, mentored 47 doctoral candidates, which is just astonishing. And he was awarded an Order of Australia for distinguished service to tertiary education and as a leading immunologist, academic and researcher. December will be the 3rd anniversary of Allan passing, and we miss the conviviality and the absolute friendship that he gave to all of us in the immunisation community, and give a shout out to his wife Diana at the same time. These are my disclaimers. I want to thank MSD and Pfizer for supporting this evening. At times I've received funding for educational activities. However, these are my views, and please make sure you read the product information. Let's talk about the scope of the problem briefly. Invasive pneumococcal disease has a wide range of different organs that it attacks. It is different in severity with different culture polysaccharides that are involved. But one of the important things is that 90% of IPD cases and deaths occur in adults. So while we've done really well with our paediatric program and the coverage and the impact it's had, the reality is that we have a major problem with the elderly. It's a continuing leading cause, and it's greatly enhanced in winter when we have co-infections due to the presence of influenza A virus. In Australia, this is data that I got from 2018 reports, 4,000 cases of invasive disease, 12,000 hospitalisations for CAP, which is a great underrepresentation because we don't tip for it, and 1,100 registered deaths. So this is a significant infectious disease that we really struggle to get on top of. Okay, the pictures haven't turned up, but these are the factors associated with a greatly increased risk. So 17 times if you live with HIV, 4 times with asthma, chronic lung disease is 10 times, chronic heart disease 4 times, diabetes 4 times, and so on. So this is a disease that if you are under 65, then there are a whole range of risk factors that greatly increase your risk of developing this. Just about all of them, we recommend that people get vaccinated, but very few of them we actually provide vaccine for under the NIP. This is what happened with IPD for older adults over the age of 70. These are the ones who are currently entitled to receive vaccine. When the PCV 13 3+0 was introduced, you can see that it really did continue the almost total elimination of the blue line down the bottom, which is the PCV7 serotypes. A continued problem and a slightly increasing problem with the PCV13 non-PCV7, and that's essentially a problem with control of serotype 3. As Angela was saying, it's got a very large, poorly bound, thick capsule, which disintegrates as it goes in, flicks around and has a whole lot of targets for our antibodies that have nothing to do with the bacterium itself, so that we waste a lot of our response targeting the capsule instead of actually targeting the bacteria. So we have an ongoing problem with serotype 3 despite PCV13, and the problem has not changed much. 13 is the non-PCV vaccine serotypes, and you can see that they still make up a great proportion. And it's one of the things we're trying to do with our new larger valent vaccines. This is the vaccine impact, and you can see on the left-hand side dramatic decreases in children 1 to 4 and children under the age of 1, but a relatively steady rate of disease in the older groups over time. And in the right-hand graph, this is an age-specific graph over the last few years. And what's happened is that while we've had great improvements in the very young, the people over the age of 65 are still developing disease at pretty much the same rate. And given that so many of us are now over the age of 65, this is an increasing burden of disease. This is the serotype distribution of IPD cases by associated vaccine. And you can see that 25% of cases, this is 2019 before the pandemic destroyed all data, that 25% were due to serotypes that were actually in PCV13, and the majority of those was actually serotype 3, which accounted for 18% of the cases. So we've got a problem with one of the serotypes in older people that keeps going. The PPV23 non-PCV, so the ones that weren't in that, have now been addressed by 2 vaccines that we have available in Australia, 22F and 33F, which are associated overseas with significant antimicrobial resistance, are in both of the vaccines. And then there are a number of other serotypes, 811A and so on, that are in PCV20, which we're now using for our paediatric program. So there's this range of 30% that are non-vaccine types that we are not dealing with at this present time, with data from the PCV13 period of time. So these are the currently available vaccines here. We no longer have PCV7 available. We're still using PCV13 in our older people. PPV23 is also still used and available for older people. And if it's in your fridges, keep it there, because it'll be many months before we have a new adult program. PCV15 has 22F and 33F, as I said, and PCV20 has those plus 5 addition. So they are the vaccines that we currently have available to us and are using in Australia. Now, the challenge with all of this is a thing called downward drift. And downward drift is a challenge because what it means is as we keep adding more valences to our currently available vaccines, they start to interfere with each other. And what we don't see is the same protection just being multiplied by additional numbers of strains. And so this is a challenge in that the more we put in, doesn't always maintain the effect. So saying that we've now got vaccines that cover a greater range is only part of the story, because what we need to know is that there's effectiveness. I want to briefly mention a thing called Capvaxive, which is PCV21. It's licensed in Australia. It's going to the PBAC for assessment in November. It's a new approach to the way we're dealing with these things. And it's something that is now being used overseas and possibly will become available as part of our armamentarium in Australia. So this is the Merck PCV21, and it is licensed. There is a PCV21 currently being trialled by Sanofi. It's not the one that I'm talking about, and that in fact is just PCV20 plus 1 additional. So it's following the tried and true model rather than this new one. And so this is PCV21. And what you can see when you look at it is many of the serotypes that were covered by PCV 13, 15, 23 and 20 are no longer in the vaccine. And what this vaccine is doing is that it's got 8 serotypes not found in any of the previous pneumococcal vaccines. And so it's relying on the premise that we will get protection from the paediatric program, as we have in the past, through to the older persons program. And rather than adding another 8, they've removed a number of vaccines 9 serotypes from PCV20, and they've substituted with others that are important in disease for this particular group. And this is 2024 data, and you can see from this that the PCV21 is actually in over 70s, covering 25% more disease than PCV20, and in Indigenous over 50, accounting for 10% more disease than that. So this is something that has a real potential for taking us a step further than we've got with PCV20. Again, as I'm saying, this also depends on the effectiveness of the vaccines, and you know, we have very little real-world evidence with either of them at the moment. One other aspect of this is that one of the suggestions from PCV15, which is made by the same company as PCV21, is that it may have some additional benefit in protecting against serotype 3 that we haven't been able to do before. There was a recent poster at ESPID suggesting that in Catalonia, the introduction of PCV15 had reduced IPD by 35% and serotype 3 by 65%. But, you know, that was a whole 200 people. And so obviously it's not something we can say is real until somebody's, you know, had much more data to have a look at that. So exciting times, both with PCV20 and PCV21, which is licensed, but at this stage, not on the program until the review by the PBAC in November. So what is the current program and what the hell does it all mean? And last year I showed a picture of the knowledge nation developed by one of our science ministers in the past, which was just a whole lot of scribble, and said that's our pneumococcal program. This year, I'm not sure it's any better yet for adults. So possible programs for adults are PCV13, less coverage than the others, the stalwart, but only one that's funded at present. PCV15 has 22F and 33F, and under the NCRS grade review says also better for ST3, PCV25 additional, and then PCV21, which is quite different in its model to the others, and PPV23, which surprisingly is still actually the policy in many countries. So our current policy is unchanged. So one of the messages is, while what I'm presenting to you is interesting and will be really important in 12 months' time, at this stage, there is no change to anybody over the age of 18. They have Prevnar 13 and Pneumovax sequentially and in that order. And if they're over 18 with a risk condition, then they're recommended to have one dose of one of those conjugated vaccines and then a dose of 23V PPV afterwards and a second dose after another 5 years. But again, only certain conditions have that fund, and they only have it funded if you use 13, not if you use 15 or 20. So what's happening in Europe? This is a statement from the steering group on the prevention of respiratory infections from the EMA. It was for Respiratory Infections Day, which is coming up next week. Average pneumococcal vaccine coverage in the EU is 24%, and they're suggesting that this will not improve until they get harmonised guidelines and agree on what's going on. And that's really important because we're all getting old. This is the current recommendation. Bulgaria uses PCV13. Slovenia, Spain, Portugal, Netherlands and England only offer PPSV23. Czechia, and Poland use both. 7 countries use PCV20. And on top of that, there are some that use one or other, some that use any, some that use 15 or 20 plus 23 and so on. It's a total confusing policy as far as Europe goes. This is the United States, which has had a fairly steadily change over time. And thank you to Nigel Crawford, who lent me the very colourful left-hand side of the screen. In 2014, when there was a lot of debate about should we use 13 or 23, they decided that they used both. So that was just after the Capita study in the Netherlands. They used both. They did a 3-year review, and at that stage they said there's actually no benefit of giving PCV 13 as well as 23. So they only gave PPSV 23 with a recommendation if you wanted to have 13, you had to talk to your doctor about it as a shared clinical decision. That changed 2 years later when they had the availability of 15 and 20, and then they got rid of PPSV 23 and said have either 15 or 20. In 2024, they licensed PCV 21, so they added that to the schedule. And this year, they actually changed the recommendation from the previous 65 to saying it's now recommended and funded through insurance and so on for everybody over the age of 50. So we're still sitting at 70 years for our older persons. They've now reduced theirs to 50. So ACIP says everybody over 50, people with specified conditions 18 to 49 should have 20 or 21. And if you can't get either of those, you are allowed to give 15 or 23, but the recommendation is 20 or 21. State variations depending on the local epidemiology, and there is some suggestions in the Western US and Alaska that you should use 20 instead of 21 because of the prevalence of serotype 4 in that particular part of the United States. NACI in Canada has gone the same way. They're saying that you must use 20 or 21, and they're saying ignore what's happened in the past, but anybody 65 and over or under 65 but increased risk should be given 20 or 21. So this is becoming the common program where both are available. So to pull this together, to reduce pneumococcal disease, we need vaccines with good effectiveness against prevailing serotypes, and we need to use them. And so why is a vaccine so poor? Because you need to be Peter Richmond to understand the program most of the time. Certainly most general practitioners struggle with long lists of who is at risk, who is not at risk, and who's able to get it funded. So there are patient factors that they don't know they need it. They're confused about the different vaccines. There is vaccine fatigue at the moment, and they're not sure how often they should be getting this. Healthcare worker factors. It's confusing, the program. They're not sure who to give it to, how serious it is. Healthcare workers need to know 3 things. This is an important disease. We have vaccines that are effective and we have vaccines that are safe. And given that those 3 exist, it's really a matter of trying to make sure that we actually get the program to them in a way that they can easily understand this in the midst of all of the other things GPs and practice nurses need to understand about asthma plans and diabetes plans and chronic disease plans and so on. And this is critical because this is, studies that have been done so many different times with focus groups and with surveys of patients. The major impact on whether or not a healthcare worker will have a vaccine, a patient will have a vaccine, is having a recommendation. If they come in and they're told, hey, you are diabetic or you're now at a certain age or whatever, you really should have a pneumococcal vaccine, then they are 30 times as likely to actually go out and get it than if you don't mention it. This is the risk conditions that's been put up earlier by earlier in the talks by Angela. So at the top of that there all of those dots, these are the people who are recommended in Australia to have a pneumococcal vaccine. It's about 3 or 4 million people with, asthma and lung disease and kidney disease and liver disease and so on. And those dots down the bottom are the people who are funded out of those 4 million to receive it. Now, the privacy laws in Australia prevent me from telling you the names of those 7 people, but I'm hoping that at some stage we can move it across to actually make it funded for all the people that actually need it. So, solution, simpler messaging, educate the public about the importance of pneumococcal disease, educate the healthcare workers, and thank you for the hundreds of people who've turned up tonight. Streamline the strategy, as we have done with the paediatric program, improve vaccines over time, improve the cost and transparency, improve access in different sites. In summary, pneumococcal disease remains a significant cause of morbidity, frailty and death. We need vaccines that work effectively. We need national programs and broader funding, and we need healthcare workers to address these with these vaccines. I believe consensus internationally is moving towards a mixed PCV20, PCV21 program as they become licensed, and I'm hoping that after the November PBAC and after the next series of reviews and tenders, that's what we have available to us in 12 months. Thanks, Peter.
Thanks, Paul. And so we do have time for questions, and we might go 5 minutes past the half hour to make up for those technical interruptions so that we can get to all the questions. I think we might start, maybe Angela, with you. The first one is about a catch-up recommendation for First Nation children who have not yet had that 3rd dose, so presumably from New South Wales, Victoria, Tasmania. They've had their 6-month routine vaccines that they would normally have, so only 2 doses of PCV13. Do we wait until do we give them the 3rd dose that they should have now straight away, or should we wait until they come in for their 12th-month dose?
Well, as of September the 1st, then they are eligible for the 4 doses. So there are some great catch-up tables, of course, in the immunisation handbook that will be specific for Aboriginal and Torres Strait Islander kids as well as the medically at-risk kids. So always use those great resources. But if you've got that nice 2-month gap, if they've just passed that 6-month landmark, etc., I think any clinician that's out there would probably be offering that dose if they're identifying as Aboriginal or Torres Strait Islander.
Yep, absolutely. I would agree with that. Now, the next couple of questions was a slightly unusual scenario, talking about somebody who's already received 3 doses of Prevnar 13, but they're all under the 12 months of age, so they must have snuck an extra dose in. Should they still get a 4th dose at 12 months of age of the PCV20, even if they've had an extra one when they were younger? So I'm not sure whether that...
it's a bit of a tricky question, really, isn't it? Because they're only, technically eligible for the 3 doses if they're not medically at risk and if they're not Aboriginal or Torres Strait Islander. I think that I think that's probably going to be a bit of a clinician's decision, to be really quite honest, Peter, as to how strongly you feel about that.
That's right. I think what I would say, although don't tell my local communicable disease control director, that I would give it at 12 months. If they haven't, I wouldn't count that one valid, because it's really that dose after 12 months of age that's really important for giving long-term protection and stopping vaccine failures, and also getting rid of carriage and transmission. Okay, Paul, this is one for you. If an adult patient with a risk condition that they had in childhood has been fully vaccinated in childhood, so has had their 2 doses of Pneumovax, what age do they need revaccination as an adult, or will that Pneumovax when they were 15 protect them for life?
No, it won't. I'm trying to think. So if they're now older and they had that when they were 2, they would have only had polysaccharide vaccine because we didn't have conjugated at that point in time. So they do need a conjugated vaccine. And if they are in a risk group, then, well, in Australia, risk groups don't necessarily mean they'd be recommended to have, well, look, I would give them a PCV 20.
Yep.
Because they have to pay no matter what, usually, because of the fact that even the risk groups aren't funded. I mean, in theory, the risk group would be entitled to a PCV 13 if they're in a certain grouping, because we're still in transition to something else. But I would be giving them a PCV 20 at this stage when I find them.
Yep, thank you. And there is one question about somebody saying, look, should they use PCV 20 if somebody's willing to pay for it, or giving them PCV 21 instead? Although my understanding is it's not yet available in Australia.
Correct.
But should they hang on and wait, do you think, for the PCV?
Well, look, I never recommend patients hanging on to wait for something. I mean, our schedule changes on a regular basis, and I think you should avail yourself of the vaccine that's available at the time. PCV 21 is not available in Australia, even though it's licensed. And if they need a PCV, they should get a PCV 20 at this point.
Thank you. That's great. So there is a couple of comments about the pneumosmart immunisation tool, saying that it's so easy to use for nurse immunisers and GPs. And the second part of that question, or another question, is that going to be updated to assist immunisation providers with who should receive pneumococcal vaccine?
Absolutely. That update is sitting on my desk. I'm slowly getting through it, and yes, I will endeavour to get that done as soon as I can, and then hand that off to the Immunisation Coalition for their techie team to get it up and running. So just be a little bit patient at the moment, but the tool is working very well for those over 18. So if most of your inquiries are regarding pneumococcal vaccine for adults, the tool is absolutely perfect to use. It's just the tweaking of the under 18s, really.
Yeah, thank you. Now, Paul, this is in answer to this is a comment on one of your recommendations, showing the Canadian approach is most straightforward to implement and practice. Is it likely that Australia will go that way for older people?
I hope so. It's certainly, I think, as PCV 21 becomes licensed in different countries, it seems that people are moving towards either 20 or 21. I mean, what you use is based on local epidemiology and local availability of vaccines. And so I think if 21 becomes available, our adult program should be 20 or 21. We don't have an ST4 issue, so we're not going to be looking at making specific recommendations for individual states or anything. I'm mindful that Canada is full of strange people like Quebecois and others, and so while the national policy said this is what it is, there's a real chance that because provinces have to fund it themselves, that they'll follow their normal policy of having 6 different programs.
Right, thank you. There was one question, Angela, for you. So if otherwise healthy children have received their 3 doses of PCV 13, then do they still need a booster with PCV 20 if they have no risk factors?
No, there's no risk factors, etc., and they've completed their primary schedule. That's all that they need. They don't need any further doses at all. And I did see a question in the box there around what is the cost of Prevnar 20.
Yes, thanks for answering
so I've just done a little bit of a Google search here, and Chemist Warehouse have it for about $115 per dose. So
that's great. And so just to clarify, we will be updating the pneumosmart tool for the person who asked that question. Paul, a couple of sort of special risk groups. Is there going to be any update on people who are on biologics or pre-biologic treatments? So I guess the expansion of biologics, particularly autoimmune diseases, but also, I guess, that's probably the main one, because most cancers will also qualify as an immunosuppressed group, immunocompromised.
Yeah, look, a large number of the people on biologics are essentially immunosuppressed because of that. I mean, the there are some worse than others. The JAK inhibitors really do knock around the responses. I think leaving out the funding aspect of it, because that's obviously not for me to decide. That'll be decided by the PBAC or the government itself. But there's certainly a recommendation for the provision of pneumococcal vaccines for those people because they are immunosuppressed. My recommendation is always for general practitioners to discuss it with the specialist starting them on the medication. And so if the vaccines can be given before they begin their course, then that's great. They'll get a better response. If not, then there isn't a risk of giving the vaccine. There's a risk of decreasing the effectiveness of the vaccine. And so my recommendation is please talk to the specialist and say, this person, if the specialist hasn't told you themselves, this person needs to have pneumococcal vaccine and all of these others. It's very safe because it's not live, but can you tell me when is the best time during their cycle of methotrexate injections or JAK inhibitors or whatever that I could give it in order to maximise the potential benefit? At this stage, we're not suggesting that people get repeat doses, or changed schedules like we do with some of the other vaccines. And so the answer is yes, give it, but please discuss when it's going to do the most benefit to the patient and be aware that there's in fact even more reason for them to have it. There's not a risk in giving these vaccines to somebody who's on BMARDs.
Yeah, thank you. And the other one that they've asked about is an adult who've had heart surgery for an aortic aneurysm repair and have hypertension and other cardiovascular risk factors. Should they be recommended to have a vaccination for pneumococcal disease?
Absolutely.
Yep. So that's answer, and that would be currently the PCV13, followed by Pneumovax. One from Liz Green, a slightly tricky one. Child coming in at 11 months of age for a 12-month MMR due to travel. Is it better to wait? And particularly if you're going to Bali, that's important. Is it better to wait until they have turned to 12 months to give the third funded dose of pneumococcal vaccine, or is it as immunogenic to 11 months? I might take this answer, actually. There is in fact, studies showing that it's at 11 months, they've looked at Prevnar 20 in Scandinavian countries, and it certainly worked. It's not magic at 12 months of age is better than 11 and a half months, but certainly 11 months is significantly better than 6 months of age. So that can be that recommendation list. They can get caught up, and obviously they're at a risk when they are travelling to those additional serotypes that may not be circulating in Australia. So I think we've answered that one. This is another interesting one. Is there any advantage for an adult using the childhood schedule if they're willing to pay for PCV20? Paul, do you want to answer that?
Look, I don't believe there's any benefit in that at all. We haven't seen any data that suggests that, that we need to boost adults to get an effect in the same way as the very primitive immune system in children need boosting. We know, I think one of the fascinating things, although they're not using 20 yet, they're still using is the UK schedule. The UK have gone 6 months, 12 months, so they've got a 1+1 schedule. So there's data out that suggests from the EMA that they don't like 2+1 schedules for PCV20 because of the failure to meet some of the immunological criteria, and they're recommending 3+1. Meanwhile, in the United Kingdom, they've got a 1+1 schedule there, and of an older vaccine. I've seen no data at this point that they've got significant breakthrough. Whether or not this is because we've got a rough idea about the correlative protection for kids that we don't have for adults, I'm not sure. But what I can say is that there's absolutely no benefit really in saying you should have 3 or 4 doses if you're an adult.
Yeah. Okay. Thanks, Paul. Now, there's just one comment that's saying it would be good to have all states having the same immunisation schedules. It could be clear and easy to follow, just like the cardiac arrest protocol. So I think we're all in agreement. Angela's nodding ahead. So last one for you, Angela. In New South Wales, I was told we don't have the option of the 4-year-old dose of Prevnar 20. Is that correct? Presumably for an at-risk child.
This is a national schedule change. So all all children, if they've got medical risk factors, and if they were previously recommended to be having Pneumovax 23, they would be getting Prevnar 20 now at that 4-year-old age range.
So I think this one's final one, Paul, for you. Any contraindications for someone who's having immunotherapy for lung cancer? Which vaccine? How many doses? I think you sort of covered that, saying that it does depend on the exact therapy, and better before treatment, but there may be a window during treatment that they can receive it. And a final one, I guess, for both of you. Has there been cases of pneumococcal meningitis in Australia? Not aware of this as a complication until recently. Tend to hear about the risk of pneumonia.
Look, there have been cases of pneumococcal meningitis. I think it's commoner in younger people than it is in older people, but it's certainly a significant proportion. I mean, I've seen figures of around 9 or 10% as part of IPD in some years, and so maybe it doesn't get enough media as some of the other things, but certainly this is a significant part of IPD.
Yeah, thank you, Paul. And it can occur in adults, particularly those with underlying risk factors who are immunocompromised. Well, look, I think we have gone a few minutes over, but it's been fantastic. All the questions have been answered that are on my dashboard. So thank you, Angela. Thank you, Paul. And most importantly, thank you for all the attendees who have come on this evening to listen to the 2 excellent talks about these changes to the pneumococcal schedule and where we need to go, and a sort of glimpse into the future. So I would just like to thank both Paul and Angela for their talks and answering all those difficult questions, and the audience for their interest and engagement. Now, just a reminder, this webinar has been recorded and will be available on the Immunisation Coalition website in about a week's time. There will also be future education events on that website and in the newsletter that they will have sent you each Monday as a subscriber, and they will be having a small evaluation survey that they would like you to complete so that we can make sure that we address your needs and issues. So from myself and in honouring the memory of Allan Cripps, thank you for joining us, and I hope it was of value, and hope to see you again next year with further updates on the NIP schedule. So please stay safe and have a good night, and enjoy to see the benefits of the additional information that we've been able to provide tonight in this new vaccine that's on the paediatric schedule and reducing the risk of disease. So thank you for everyone. Thanks. Good night.